Our next presenter is Dr. Matthew Rafalski. Dr. Rafalski is a family physician who's been in practice for 16 years. For the past 13 years, he's been at Dayspring Family Health Center, which is a community health center in the heart of rural Appalachia. He's the clinical IT director at Dayspring, and his IT interests include patient-provider relationship and communication while using the EHR, clinical decision support strategies, development, and QI/PI. So with that, I'm going to go ahead and turn it over to Dr. Matt.
Wow, I feel like if I had these three guys on my care team, I could take over the world, right? Yeah, that's amazing. There we go. So, Dayspring Family Health Center, another FQHC. We're a lot smaller though. So we're about 8,000 users, 30,000 visits a year. We have 3 clinic sites, 11 providers, 3 care managers. We do all the medical home and all that jazz. So what I'd like to share with you guys today is our specific journey with some of the tools with i2i. It's really easy to get overwhelmed. There's a lot of cool stuff in Trax, and there's a lot of cool stuff in Team Intelligence. And there's just so much that it's easy to get overwhelmed. It's easy to not be able to figure out where to start. And so I want to share you with our journey about how I visualized the implementation and how we actually went and rolled it out and some of the things that we've been able to do to bend the software to our advantage to be able to take care of our patients better. This is our path, so it's not necessarily the right way to do it, but it's the way that worked for us. We are just scratching the surface, so all of the stuff that you see is really, really cool. But there's a lot deeper that we can go both in the individual items that we're doing, but also there are new and unique ways that we can use the software that I haven't even been able to think of yet. So one of the things that I certainly want to encourage you guys is start small. Don't get overwhelmed by all this. This was a journey, not a start. And we're still on that journey. We're still continually adding things on. And so if there's one piece of advice I can give you guys is just start with one item, one thing, one tool. Get that working right, get that working well. And if you get it working well and you get it to be what the providers need, you're going to have those touchstone moments like Michelle was talking about where the provider goes, ooh, I like that. And boy, then you're off to the races because all of a sudden you've got them on your side. And when you come back and say, hey, I've got another tool for you, they're like, is it like that other one that really, really helped? And you can say, yes, it was. And then you're in. And actually, even further down the line, if you get enough street cred with them, you can tell them up front, this is really not going to work so well, but I really need this data. Can you push that blue button for me, please, please, please? And they'll, even at that point, once they're on your side, once they understand what you're all about, it'll really help to get them engaged to do that. So, all right. So, take nothing else home. This is what it's all about, okay? You get the right information to the right team member at the right time, right? You guys have heard this before. Go ahead and say it, because I need you guys to take it home. It's the... Oh, more enthusiasm. Come on, get excited. If you guys aren't excited about it, the providers are not going to be excited about it. So it's right information, right team member, right time. All right, thank you guys very much. Because this is the way that I think about each of the tools in both the EHR and in the population health software. I've come to think of them, it's like a diagnostic test. So when I implement something, I want to know what need is it going to meet, what question is it going to answer, or what action is it going to cause. And if I can't answer at least one of those 3 questions, and I can't apply these 3 items to it, then I'm not going to implement it. I've got to scratch it and start. I don't care how cool the tech it is. I don't care how fancy it is. I almost don't care how much my CFO spent on it. If it's not going to work for our providers this way, I'm not going to implement it because this is what it's all about. And this is what's going to help you guys have those touchstone moments to make your providers more effective, okay? And I've been thinking about things as a meta chart. So when you go in to look at a patient's chart, you know everything about the patient today and in the past, right? i2i is like a meta chart. So it's going to let you know about things in your whole clinic and in your whole organization and in your whole, hopefully, county and population, past, present, and future, okay? So the dashboards for us, that looks at needs across the organization. So we use that to get us information about what's going on in our organization. It's a little bit of historical data, so it's not going to tell us right now, but we'll use it in ways to make decisions for what we need to do and where the needs are. Morning huddles are needs across a provider's day. It lets the provider start at the beginning and see everything that needs to be done to the patients that day. And like we said in the last session, I'm not expecting them to go through the entire morning huddle and check off every list. I want them to hit maybe one or two things, but allows that to sear that into their head so they don't miss those things. The Today screen actually allows us to see needs across the clinic and across the organization, and that's the way that we've used it. It can be used in several different ways, but the way that we've used it is to know for our care managers who are not fixed to a schedule, they've got to our care managers take care of about 3 providers. It allows them to know across those 3 providers who are at that physical building right now, when are the patients with the highest needs going to be there so that they can set their day and set their schedule so that they don't have to wait for the providers to come to them. They can actually go out to the providers and the patients ahead of time. And of course, the population lists are what we're using to look at needs across groups of patients and to see what we can do in the future to take care of them. So let me talk about how we use each individual item. And we'll go from there. So the dashboards, of course, are needs across the organization. These are our flow charts that we use to look and see where our problems are. Do I show these before the provider, before they go in to see the patient room? Of course I don't. Is that going to cause them to make a different decision? No. Where we use these is when we're sitting down in our strategic planning sessions and in our quality meetings, which we do monthly and quarterly, to sit down and say, okay, what do we need to do to improve these numbers? And some of these numbers, as you can tell, like our depression screen, we're not doing too bad on that. We know we're doing okay. If you can see our SBIRT screening, if you can see our SBIRT screening over here, you can see we started off a big problem. We were doing really lousy on follow-up on SBIRTs, positive SBIRTs. And we said, hey, we need to come up with a big program for this, and so we did. So that's how we use this kind of data. Now, do we present it to the providers? Yeah. Do they get a whole lot out of it? Maybe they get the little competition things going, but honestly, our providers are so overwhelmed at this point. When they look at it, it's kind of I use it to more pat them on the back than they're doing well. If they're not doing well, I'll sit down and have a chat with them and engage them and say, okay, where are you struggling? What do you feel like the problem is for this particular item? Why is it you feel like that when your patient has a positive SBIRT screen, it's not getting followed up? And they'll give me some information, and we can take that back to our team, which right now consists of me but a few other people, and I'm slowly building the team around me as we go. But I take it back and say, okay, what kind of resources can we throw at this person to help them do a better job? And of course, we use the IPHA reports in the same time. They give us a little bit more numerical data so that we can sit and look and make some comparisons as well. And we've got all kinds of different reports that we can use. And these are things that I've been able to create with i2i. So they're things that as you guys learn, as you guys go to i2i University, you get the training, you can write these all on your own, and you can basically measure almost anything you want to as long as it's in your EHR as structured data. So again, various things that I've done with our system as far as that's concerned. So morning huddles. Morning huddles, we started with nothing. Yeah, so we didn't know what the heck was going to happen today. We had a schedule, and you kind of get to know your patients. Like you can say, I know that person's going to take a little while, and or this person's going to be quick and easy. Then we started with what we call our EHRs, morning huddles, which was basically the schedule list with a single item on it that flagged patients that were high risk for us. So we had basically an asterisk that said, this person's high risk. Now, it didn't say why they were high risk, so I had to guess, Miss Jones, I think she's got diabetes, maybe blood pressure. So my nurse and I would go back and forth trying to figure out what it was that they actually had and whether or not we need to do anything with them different than what we were going to do. So again, not really any decision getting made out there, but we did it because we had to. And then i2i Tracks came along, and boom, oh my gosh, we had morning huddles that had information about immunizations and colon cancer screens and breast cancer screens that we needed to do. Still some limitations. We weren't able to customize it some of the way we'd like to. Far too much data on there that we didn't need and not enough data that we did need. And then, of course, Team Intelligence came along and really knocked it out of the park. And so this was our morning huddle from our EHR, which, like I said, all that we had was this cute little code here that says PMH, patient medical home. And that was sort of our highlight to say, this is a needy patient, but it didn't give me any idea about what they needed or what I needed to do to do a better job taking care of them. We then moved on to tracks, and this is the morning huddle on tracks. You know, it's a little bland. You don't have any kind of separators, and the patient's names would be right there, and they're blocked out. You do have a little bit of information right there about something that they might need done during the course of the day today. But again, a lot of limitations. The data kind of trails off this way, and it gets lost. And if you have ADD and all, you're like, oh, look, there's that, and there's that. Oh, look, there's a squirrel over there, and you're kind of lost. So hard to look at that and make any much sense of it. Although it was a big improvement for us over what we were doing before. And then here's team intelligence. And the beauty of team intelligence is you guys have probably seen some of these today already. You can do as much or as little with this as you want. As we talked about in the last session, what I did, just like I did with the clinical decision support in our EHR, I started by turning everything off and shut everything down and said, okay, you know, what's one or two things that the providers need to be able to make decisions so that I can bring that to their attention. Slowly over time, the most exciting days of my lives was when the providers come to me and say, hey, can you add a clinical decision support role for this? And I'm like, yes, I did it. Kind of like Michelle was talking about with the immunizations. The immunizations on this are amazing. Not only does it tell the nurses that the patient needs immunizations, it tells them which ones they need. And the nurses were absolutely beside themselves because prior to this, they had to look at a long list of immunizations that unfortunately in our EHR was not in any kind of order except maybe alphabetical, and you know that doesn't make any sense when you look at the things. So being able to tell that, it's saving time. So they're able to make a decision right at that moment about what needs to be done with that patient, and it burns in their brain. You know, I may get chaos going on. I may have a work-in happen. Certain patients may not show up. But today I know little Johnny's been without his immunizations for a year now, and we're going to get that done today if we don't get anything else done. So when we use the huddles, the biggest thing I emphasize to my providers is don't get overwhelmed by all the data. What I want you to do is look over it, and I want you to pick maybe the 2 or 3 most critical things that you don't want to miss today. And that's what it's there for. We talked about in the last session, you know, the thing that I didn't want to miss that one day was that my one patient had a positive depression screen. I had no idea that she was depressed, but it had never been followed up on because the visit was so busy last time it got missed. And I was not going to miss it that day, and I didn't, and it had very positive results. So helping the providers look through some of this data and use it to kind of hit the highlights of the day to make sure that they don't miss the most important things is where we've come in handy with this. And again, we've got different reminders that you can see on there. The protocols were probably the next biggest innovation because we can add things like, oh yeah, this patient's seen our care manager already, and our care manager, our doc knows, hey, I don't even have to do a referral on this person. The care manager already seen them, care manager already knows about it. They're going to follow up on them and take care of that. So things that we've put on there, we do immunization schedule is huge. We use our protocols to detect things like our SBIRT screening. So when the patients had a positive SBIRT screen and they need follow-up on that, if it got missed, it'll be on there. Depression screen the same way. We do adolescent risk screens, and for us, we have a little trouble making sure that they get done, especially since most of our adolescents are work-ins or at least sick visits that don't get added on until last minute, and so catching those are really helpful. And then, of course, we do our PCMH high-risk patients with the little blocks along the side and in care manager referrals as well. All right, so today's screen. So you know, the reports and the graphs told us about what we've done in the past. The morning huddles tell us about what's going to happen that day for the provider. The today's screen we've used to help us see what the needs across the clinic are going to be for that day. And this has been revolutionary for myself. It actually dawned on me while I was running. I don't know why I didn't think of it before that, but we were like, I think we were 8 months into it, and I was like, I just don't know what to do with today's screen. I was out running one day, and I was like, boom, all of a sudden it hit me. Wow, this is what we can do with this. So basically how I've designed the today's screen is it looks at patients who are going to be at that clinic today. So you use the appointments feature in a search to say who's going to be in my clinic today. And then what you do is you look for particular indicators that you want to track up on. For us right now, you know, who in my clinic today has an A1C greater than 9? Who in my clinic today has a blood pressure under control? Who in my clinic today has a depression screen that hasn't been addressed or an SBIRT that hasn't been addressed? And of course, what you can do then is you actually click on this, and it actually opens up the search. So not only does the care manager know that one person is in my clinic today who has a positive SBIRT, but they know who it is and when they're going to show up. They know when the SBIRT was done, and I've got some other information that I've customized on the audit screen that allows them to look at all the information they need to do it. They can even print off, if it's like a diabetes issue, they can even print off some of the customized patient information and patient handout forms that are available in i2i ahead of time so that they can take it right in there. So I've got my care managers now going in to see the patients before I even get there. They've already done their diabetic education, taught them, encouraged them. I come and the patient says, Doc, I'm going to work on my diabetes. I'm like, that's great. Where'd that come from? I was a care manager. Loretta already saw me. She's got it taken care of. I'm like, okay, well, my job's done now. wish it was that easy, but it does allow me to interact with the patient to make some of the critical decisions that we need to make as physicians, where some of the education material has already been done, and it allows me to reinforce. So if oftentimes Loretta and I will pass in the hallway and say, hey, I saw Miss Jones. Hey, Miss Jones is going to work on her diet. Now I go in, okay, Miss Jones, we're going to work on her diet, right? She's like, yep, we are. So there you go. So as far as our care management, that's gone from nothing. Initially we were doing referral at the time of care. So if I were seeing a diabetic patient, once I got done the visit, the patient was back in control, I'd refer to the care manager. Sometimes our care managers are there, sometimes not, because we're a small organization. Sometimes they're at another clinic. Sometimes she's attending a community meeting to find out resources. So the Today screen allows her to plan her day and shift things around to make sure that it works for them. The MDs, we did the morning huddle, and then of course with i2i, the search list and the reports and the Today screen have been really huge for us. And then finally, the report and search screens, again, we use these for outreach, and this has been where we've been able to look into the future, if you will, see the needs across our organization, and be able to make some interventions based on that. And probably the one that I'm most excited about, and I'll close with this, is our mammograms. So we do Komen mammograms. You guys familiar with the Komen program? So our patients who are uninsured can get free mammograms. And our rates are a little lower than we like. We usually end up with leftover money at the end of the year. Our rates are trickling around 40%, which is not good at all. And so based on what the insurance companies are doing, I went to my head nurse and I said, do we have a little extra Komen money? She said, yeah, we have a little extra Komen money. I said, well, what would it be if we provided guest cards if our patients were to go get mammograms done? She said, let's see if we can get permission to do that. So she talked to the Komen folks and they said, well, yeah, if it encouraged them to go get mammograms, I think that's a great idea. It's a good pilot program. Because for years, of course, I've been telling my patients, go get your mammogram, go get your mammogram. They're like, no. And then what happens? Humana offers like a $10 Amazon gift card to go get their mammogram. They come in and say, hey, doc, can I get my mammogram done? Well, that may be healthcare of the future, I guess. So, I don't know. You can see it happening, can't you, where you're saying, okay, Humana's going to offer me $10,000 if I can get my mammogram rates up to 85%. If I spend $2,000 on gas cards, that gives me $8,000 profit, right? Boom, there it is. I'm not sure how I feel about that, but it seems like it might work, and indeed it did for us. So we actually took our screening rates from about 40% up to 50% over the last couple months based on being able to offer this program, and it's something that we hope we're going to roll out based on our success with this program, but it came from running the search list. So basically our head nurse, she printed out the search list, who of our patients who are not insured, so socioeconomic determinants of health, who are not insured, who have not had a mammogram, who are still our patients, whether they've been seen or not in the last 2 years. And then she just started running the list. We sent out letters, we sent out flyers, and boom, we got all this excitement about it, brought these folks in, and we were able to make a difference on that. So that's been a big impact. And these are some of the other things we've done. Of course, we work with Vaccines for Children. A lot of that data now gets done automatically as far as the tracking and registry, so that we don't have to do it by hand anymore. Uniform data set is push button now, which is amazing. PQRS we've done. We do vaccines calls, so our vaccine rates are above 90% right now, and that's thanks to a nurse that runs that list on a regular basis, but it's a search list that's created in i2i. We have safety net data that we have to report meaningful use, and of course our own clinical quality stuff. So I'm going to finish there so we can take some questions. Thank you guys very much.